kickoff time is in just under an hour's time. Is that correct?
Yes, sir. Should I give you a call or a WhatsApp text once it starts, like 5 minutes before?
If I'm not, if I haven't appeared, yes, do that. But I should be. I should appear. Now I've got a huge favour to ask. It may not be possible. If it's not possible, that's fine. But I have a 98-year-old aunt who's in hospital with a broken hip, and I need to go and visit her if I possibly can. Is it possible? Is it possible to flip the order of the two talks, or is that going to be very difficult
Yes,
for
yes,
you?
it can be done. Your talk can be first.
Do you mind? I'm really sorry to inconvenience you, but
No, no, not a problem at all.
okay. Well, so if I come on 5 to 10 minutes before the kickoff time, and just be ready, um, that sounds great. And thank you very much for asking me. And
5, 4, 3, 2, 1. Please proceed the session.
Good evening, faculties. Very warm welcome to all. Every year we hold this very interesting scientific session and discussion to observe World Asthma Day, to create more awareness regarding World Asthma Day, whatever newer updates in the treatment guidelines, in the management of asthma, more relevant to the clinical practice. So all these things are discussed, which I am sure as pediatricians, you all daily, on a daily basis, face multiple queries, very unique cases. So we have international speaker, Dr. Andrew Bush, and all the top pediatric pulmonologists of the country, Dr. Indu ma'am, Dr. Subhashish sir, Dr. Modak sir, Dr. Prakash Vaidya, and Dr. Sharad Balaji, who will share their technical insights. So before we start with the session, I would like to invite Mr. Chitranjan Dhiodar, the senior GM of the Lupine marketing team, to give a slight overview of the Lupine corporate presence. Over to you, sir.
Are we good? Thanks, Jinsi, and welcome to all the faculties and participants who have joined us online. Today is a working day and little tough, and we're expecting some people live audience also here very soon. I'll be a little brief and try to take you through the corporate overview of Lupine, just to give you a little insight. How do I change the slide? I'm so sorry. Yeah. We begin normally paying homage to our founder who started this organization in 1968, about 54 years back. And we are very proud to share that today it's a global player to reckon with. Across the globe, actually, 10th largest generic company, 6th largest Indian pharma company. We are the 3rd largest in US and 6th Indian pharma company as per market rank. While API contribute about 6%, a majority of our sales historically comes from North America, followed by India, which is now a little higher at 38%, ROW, EMEA, and the growing markets. We have about 15 manufacturing sites across the country, 7 R&D sites, and 1 R&D sites in Miami, which is dedicated for respiratory. Like I mentioned here, the workforce in these 15 manufacturing sites, research, and across the commercial teams is in the excess of 20,000 people. A map to show you where all we have our footprint across the globe. We specialize in most of the therapies that we offer in the therapeutic management of various diseases, which starts from API to specialty drugs, going across generics, complex generics, NDDS, and we also have some presence in OTC. We started our journey being strong in antituberculosis, but today cardiology, diabetes, and respiratory are our key pillars in addition to our presence in CNS. Like I mentioned, our people is our strength or force of good, and hardwired in them is a culture of innovation, empowerment, collaboration, and for a better future. These are some of our values, which include integrity, passion for excellence, teamwork, entrepreneurial spirit, respect and care, and customer focus. Let me focus on a little more on the India region where this team belongs. We are ranked like 6th with a market share in the excess of 3.5, double-digit growth, little about 10. And we have about 8 brands which are over 300 or in the top 300 in the IPM. Among the focus therapy areas, respiratory is where we are ranked number 2 with a growth of about 14%. We have 36 strategic units or divisions, as we call them, in 23 therapy areas. And if you can put a finger anywhere on the map in India, we would be able to help you at any place with a person from Lupine to cover. We have about 7,000 plus reps, and the sales hierarchy adding up to almost more than 9,000 people. Not only is our people our strength, but our distribution network also boasts of central warehouses, 27 distribution centers, in the excess of 4,000 wholesalers, more than 700,000 pharmacies, and excellent cold chain capabilities because of our presence in vaccines and many other products which require cold chain, like our insulin range. More about the respiratory franchise. This is now updated to almost touching 1,000 crores at 998 crores, is a pure respiratory portfolio in Lupine. It's spread across 5 teams, and the team that is engaging here is the Lupine Spiritus team, which has a very strong presence in pediatric pulmonology too. 998 crores, second largest player in respiratory segments. We have 4 therapeutic areas which we cover, more than 60,000 HCPs, and a manpower of almost 1,800 plus, 1,834 to be precise. We have a reasonable 20% share in the inhalation therapy, and we are the second largest also in the pediatric respiratory. Some key brands where our market shares are in the excess of 66%. We have a very strong track record of building mega brands in this therapy, and it is your continued support which has helped us to get here. Like I told you, I'll be pretty short, and thank you very much for your attention. And I request Jinsi to take over from here. Thank you, Jinsi.
Thank you so much, Chitranjan sir. So I would like to invite our scientific chairperson, Dr. Indu Khosla, to give the introductory remark.
Thank you, Jinsi. It's indeed my pleasure to be amongst all these, elite academicians today on the World Asthma Day. World Asthma Day is celebrated on the first Tuesday every year in the month of May. It started way back, I think way back in 1998, where the first World Asthma Day was celebrated with 35 countries, and it was held in Barcelona, Spain. And the aim of the World Asthma Day is basically to increase awareness and improve care when it comes to asthma. So we all know there are a lot of gaps, and I'm sure we will hear Andy speak about it. The gaps that we feel and the panel discussion to follow will also help us know where we stand today and where we can improve. Very rightfully, this year's theme is Asthma Care for All. And we definitely know that there is loads to improve, especially for the lower middle income countries, where the care, there is lots to desire, and there are lots of gaps that we even currently see in the management of asthma. With these few words, I would like to invite our speaker, the one and only Dr. Andy Bush. He's an expert in his field in pediatric pulmonology. And if I read his degrees, I think it's from A to Z. That's all that I can make out of it. He has every possible degree that any person as a respiratory specialist could get. To me, he's a go-to person. Whenever I have a tough case, the first thing that I do is I just type it out on my email and I send it promptly to Dr. Andy. And trust me, I get a revert in exactly 5 minutes. And that's what's Andy to me, to a go-to person for any complicated case. He's a professor of pediatrics and pediatric respirology at the National Heart and Lung Institute, Imperial Center for Pediatrics and Child Health, Imperial College. He's a consultant pediatric chest physician at Royal Brompton and the Harefield NHS Foundation Trust. Over to you, Andy. We all look forward to hearing you.
Thank you very much indeed. I'll just you need to unshare your. You've done it. Thank you. Thank you very much indeed for the invitation. And thank you also, and thanks to the organisers, and thank you also for allowing the order change. The audience, there's a family health issue that I need to address, and I'm really grateful, and I hope this has not caused inconvenience. So I've been tasked what to do when asthma treatment is not working. I have no conflict of interest with regard to this presentation. What I aim to do is that if show that if treating asthma is not easy, then the reasons likely lie outside the airway. And I hope to convince you that the best approach is usually a protocolized systematic evaluation of the child rather than adding more treatment. I probably not have time to do smart approaches, but I'm going to discuss novel treatment approaches. The main thrust is that most children need to get the basics right and don't need exotic options. So one background slide, an unresponsive asthma. So this was an excellent North American study where they posed the question, if you're still symptomatic on inhaled corticosteroids and long-acting beta agonists, is it better to add a leukotriene receptor antagonist or azithromycin? And the whole study ended in futility, as most of the patients they screened either did not have asthma or were not taking their treatment. And that's an important lesson, that if you take your treatment, you generally do very well. And the Badger study, another brilliant North American study, they showed that most children with asthma do not respond, do not have any extra benefit from going above 200 micrograms of fluticasone a day. I'm sure many in the audience will recognize this famous picture of Christopher Robin taking Winnie the Pooh upstairs, bump, bump, bump on the back of his head. Well, Christopher Robin is like a pediatrician, put Winnie the Pooh like a child. These are the steps he's being dragged up, and it's costing a lot of money. And actually, most of these steps are not evidence-based. And in fact, we use too much inhaled steroids when we actually need to find out why the steroids aren't working. So what's our clinical approach to the problem of a child referred to you with asthma that is not responding to treatment? So the first question, of course, is does the child have asthma at all? What's the evidence? And we've really got to make sure we measure, and this is something that we don't do well in the United Kingdom. Does the child have a disease at all? And we need to know the limits of normality. Is there positive evidence for an asthma diagnosis? And is there evidence for an alternative non-asthma diagnosis? So here you can see a flow volume curve, and you can see the expiratory limit of the flow volume curve is very attenuated. The volume time curve is a straight line. This clearly is not asthma. This is somebody who's got a large airway obstruction, and in fact, this patient had a vascular ring. What about evidence for asthma? Well, I think at all ages, we need to attempt to find physiological evidence of variable airflow obstruction. In my country, most asthmatics are atopic, and we look for that. And we look for evidence of airway inflammation. So in terms of physiological evidence of variable obstruction, acute response to a beta-2 agonist if the peak flow is low, a field exercise test, does the child bronchoconstrict, or 2 weeks home peak flow monitoring. No more than that, because after that there's patient fatigue and they stop doing it. We look for evidence of atopy, a history of eczema, food allergy or rhinitis, skin prick test or specific IgEs. And increasingly we are looking for evidence of a raised exhaled nitric oxide. And I'll talk a little more about blood eosinophil count presently. Induced sputum, if you have access to it, to see if there are eosinophils in the sputum. So if you're satisfied now after your workup that this patient really does have asthma and is not responding to treatment, our next step is a multidisciplinary team evaluation. And this includes visits either virtually or in real time to the home and to the school. We look about adherence. The single biggest factor in my clinic for patients not responding is poor adherence. So we ask, have they picked up prescriptions? Of course, if they pick them up, it doesn't necessarily mean that they've actually used them. Increasingly, we're using electronic monitoring. In the home, is the medication in date and accessible? It's the major obstacle to effective management is adherence. Biggest single reason treatment fails. And it's worth thinking about this in terms of the PAPA framework, reasons for non-perceptions and practicalities. And practicalities, is the regime very complex? Is the lifestyle chaotic? Are the parents supervising the children? Is the regime too complex? Is there a stigma? Does the child not want to be seen to be different? Perceptions, lack of understanding of the correct usage, the feeling that why do I take inhaled steroids when I don't get immediate change? Concerns regarding side effects. Absolutely essential to talk about adherence. And if somebody is not adhering to treatment, it makes no sense to give them yet more treatment. We use electronic monitoring with these devices. They only measure activation, not the child's inhaled. And this is a common scenario that you see here. Their adherence is good when we're doing the monitoring. Before the monitoring started, FEV1 was low, nitric oxide was high. At the end of the monitoring period, everything is normal. And what this means is that the patient was not taking the treatment before we started monitoring. When we started monitoring, they started to take the treatment and it works. We also see those who have poor adherence and don't improve, even being monitored. And these are either people with refractory severe asthma, these are patients who just simply won't take their treatment, or severe therapy-resistant asthma. They've stopped taking treatment because they're fed up with it, it doesn't work. And those with good adherence but still bad outcomes, these are the true severe therapy-resistant asthmatics. And those with poor adherence but good control are likely the ones who are being overtreated. The environment. Cigarettes, and in my country, vaping. Are the children being exposed to nicotine? I believe in India, you are being much more effective in dealing with the menace of vaping than we are in the United Kingdom. What about the environment? Are they sensitized to allergens and exposed to allergens? In England, the pet cat is the obvious one. And finally, psychosocial, anxiety and depression. Or are they exaggerating symptoms? And it's worth asking the school about what happens at school. So what we try to determine is, is this child whose treatment isn't working, do they have asthma plus comorbidities? Do they have difficult asthma where they just need the basics to be got right? Or do they have true severe therapy-resistant asthma? And the team puts together a bespoke treatment program, and many of these children are no longer problematic when we've sorted out their environment or sorted out their adherence. We do, however, have a group of refractory difficult asthma that we cannot get the basics right, or asthma with comorbidities that are not addressed. The refractory difficult asthma, usually non-adherence in the environment, and refractory asthma plus is usually obesity with failed weight loss. The differential diagnosis is exaggeration of symptoms for hidden or obvious gain. In my country, if your child has severe asthma, you can qualify for government benefits. Look for ongoing poor control and attacks and ongoing allergen and tobacco exposure. Ongoing poor adherence despite multiple efforts, and of course be aware it may be that they've stopped taking the treatment because it doesn't work. Think ongoing adverse psychosocial factors, the 3 Ds: denial, depression, disorganization. Most asthma groups in my country, deaths in my country, are in this group. So is the child non-adherent child treatment responsive or disillusioned because treatment didn't work? And so what we then want to know is what happens when the treatment is actually given. And we use directly observed therapy. You're obviously all familiar with that with TB and other contexts. Directly observed outpatient therapy, admission to hospital for directly observed therapy, or sometimes a therapeutic trial with a depot steroid injection. And if they respond to treatment, we continue either with directly observed therapy, either at school or sometimes by video link using mobile phone technology. If they don't respond, these are the ones with severe therapy-resistant asthma, and they will go on to biologics, which I'll discuss in a moment. So here's a girl with asthma not responding to therapy, a 15-year-old girl, a near Olympic standard swimmer who had noisy breathing and respiratory distress towards the end of the races and afterwards. Impairs her performance, doesn't respond to treatment. A diagnostic test was performed, and the diagnostic test is something we can all do. All what we need is a smartphone. So we do a video, and let's. This is not asthma. Stridor or exercise-induced laryngeal obstruction, vocal cord dysfunction. If you can diagnose it in the laboratory by laryngoscopy during exercise. You can see this man is on a bike. He's got a laryngoscope down his nose, and you can actually see the vocal cords. And what you see with this condition is the vocal cords adduct come together in inspiration, hence causing the stridor. This may coexist with asthma and enters the differential diagnosis. And the differential between exercise-induced bronchoconstriction, it's common, it occurs in 90% of asthmatics, but usually comes on after exercise. They find it harder to breathe out, and it's usually blocked by salbutamol pre-treatment. Whereas exercise-induced laryngeal obstruction, the symptoms start during exercise. They find it difficult to inhale, and it's not helped by asthma medications. And finally, the obese or deconditioned patient, they get symptoms during exercise, they feel breathless, it's not helped by asthma medications. And if you're trying to sort this out, a cardiopulmonary exercise test is an excellent way of doing it. So what are the new treatment options that we have? And the biologics, and I want to stress that of the children referred to me for biologic therapy, about 70% do not need it. They just need to get the basics right. This cartoon shows what is available for us, and we have omalizumab in the an anti-IgE monoclonal, mepolizumab, which binds to circulating IL-5, and just become available, licensed in our country, is dupilumab, which binds to IL-4, IL-13 receptor. So what about omalizumab? It binds to IgE, it prevents binding to the high affinity IgE receptor on mast cells and basophils. You can see in this cartoon here, but what it does, it reduces the expression of these receptors, reduces tissue infiltration with eosinophils and mediator release, and damps down allergic inflammation and exacerbations. And this is the medication with which we have the most experience. In my country, you have to be 6 years and over. You have to have at least 4 prednisolone bursts or be on continuous steroids. The 4 prednisolone bursts is actually ridiculous, because if you've had an asthma attack and you can't prevent a second attack, you're certainly going on to have a third attack unless something is done. The dosing depends on the weight and IgE levels. Again, check your Indian guidelines. IgE has to be 30 to 1300, but about a third of my really difficult asthmatics have an IgE higher than this. It's very expensive treatment. It has to be administered in hospital with observation afterwards for risk of anaphylaxis. Although in the COVID pandemic, we gave the first 2 or 3 doses in hospital, and the rest were given by the mother at home using FaceTime as a video link to the nurse who could witness the injection in real time. The evidence reviews, well, there's a lot of data. Omalizumab reduced asthma attacks, asthma hospitalization, despite being able to cut inhaled steroid dose. In 5 real-world studies, evidence of benefit with reduced steroid dose. And in children, 6 years and older, 10 pediatric studies, better control, fewer attacks, less inhaled corticosteroid. What about mepolizumab, which is the anti-IL-5 monoclonal antibody? What it does, IL-5 regulates the growth, recruitment, activation, and survival of eosinophils. And you can see in this little cartoon, IL-5 causes the eosinophils to mobilize to the blood from the bone marrow and exit to the airways. And this is blocked by mepolizumab. But they also have there's a second pathway, an independent eosinophil compartment, which is activated. It's now licensed for children of 6 and over. And what we don't know, however, are the biomarkers of response in children. And I want to show you the Muppets 2 study. So Muppets 2 is a double-blind, placebo-controlled, randomized controlled trial. It was at children aged 6 to 14. They had to have at least 2 attacks in the previous year, and they were on step 4-5 treatment. And they had a blood eosinophil count of more than 150, which is actually well within the normal range for children. The primary outcome was the number of attacks treated with oral steroids. And a great study, nearly 250 patients completed the study. And you can see here, this is the total number of the patients who remained free of exacerbation. And you can see the blue line, mepolizumab. Yes, there is a small effect, but it is very, very small. If you do a sort of subgroup analysis, it's more significant. If you use MEPO just to stop the autumnal surge in exacerbations when they go back to school, it looks impressive, more impressive. But I want you to contrast the top right-hand panel with this adult study, the DREAM study, where you can see actually the effect on asthma attacks is much, much, much more dramatic in adults than children. And this is a really important point that we need to think about. We cannot rely on adult data to tell us what to do in children. So there are no studies comparing mepolizumab to omalizumab. There's something called the TREAT trial, which my colleague, Professor Soglani, is running. It is going on. So what about dupilumab? This blocks the IL-4, IL-13 receptor. And this was a very good 52-week placebo-controlled trial in over 400 children aged 6 to 11 years. And they gave subcutaneous dupilumab in a weight-dependent manner. The primary endpoint was annualized asthma attacks, and you had to have a baseline eosinophil count of at least 150, or a FeNO of more than 20. And that's they call the type 2 type, or a blood eosinophil count more than 300. And in all groups, the results were the same. There was a reduction in asthma attacks. There was an increase in FEV1. There was a better quality of life score. And these are some of the results. You can see here the annualized rate of severe exacerbations, whether you had the type 2 inflammatory asthma phenotype or had a blood eosinophil count of more than 300. You can see there is a dramatic reduction in asthma attacks. There was, again, a 10% improvement in dupilumab in all groups. There was better asthma control in all groups. The results were the same whether you were in the type 2 inflammatory asthma phenotype group or had an eosinophil count of more than 300. Dupilumab was safe, but interestingly, and I'm going to come to that in a moment, there are more viral infections in the dupilumab group. So what do we know about markers of eosinophils? We know that induced sputum in preschoolers is a poor marker of airway cytology, but in school age, it's really quite good. I would suggest that if there is no blood eosinophilia, it's likely there's none in the lavage. But, of course, blood eosinophilia may be driven by other atopic disease. It can certainly, in high parasite burden areas, be driven by by parasite infection. And if you look here, this is a very important paper on what the normal blood eosinophil counts are in children. You can see the cutoff of 300 in adults is very reasonable, but actually the normal range of eosinophils is much higher in children. So we need more data to understand who should have what biologic. And what about the infection risk? And this is an adult study, and they compared reslizumab, which binds to binds to IL-5, mepolizumab, and benralizumab. And whereas Resli and Mepo bind our circulating IL-5, benralizumab binds to the receptor. And benralizumab virtually obliterated sputum eosinophils. So you can see here the reslizumab on the left, mepolizumab in the middle. Look at benralizumab. Virtually all the patients had a complete response with no eosinophils at all. However, there were increased total infections after starting benralizumab, and we have to be aware that God gave us eosinophils for a good purpose. So here you can see pre and post treatment on benralizumab, the total number of infections increased, and those who had asthma attacks on benralizumab were infective, non-eosinophilic, as opposed to eosinophilic on Mepo and Resli. And benralizumab, there were more infections compared with other patients, with the other monoclonals, in all patients and those with suppressed eosinophils. So here you can see all patients, benralizumab on the left, more infections than either of the other. And those who had zero eosinophils, again, benralizumab, more infections. So we have to be aware that there may be a downside to the use of monoclonals. They can be dramatically effective, but we need to think carefully before deploying them. So where are we? We've still got much less data in pediatrics than we have in adults. And one of the things that we really must do as a group of pediatric pulmonologists is to do decent studies, get studies done in children and not rely on adults. There are potentially useful monoclonals not available to us. And worryingly, monoclonals which don't work in adults are never tried in children. And that may be a wrong assumption. And we need to remember that we, not just in high parasite burden areas, but not all eosinophils are the bad guys. And it's clear that if you dramatically wipe them out, this can cause problems. So what then are my take-home messages from this talk? First and foremost is that most children with asthma respond very well to low-dose inhaled corticosteroids if the medication is taken regularly and correctly. If they're not responding, don't keep on giving more and more medication. Ask, why not? Why are they not responding? And the answer will usually be the diagnosis is wrong, or they're adhering poorly to treatment. And over again, getting the basics right. I cannot stress this too much, but in my country at least, I'd be interested to know about India, but in my country at least, frequently the basics are got wrong. Wrong device. The patients aren't taking the treatment. The parents are puffing tobacco smoke over them. For the genuinely severe asthmatic and those with refractory difficult asthma, think about the new biologicals. So I'd like finally to thank all the funders, particularly Asthma UK and the Asthma Centre for Applied Research. And I'd like to thank you for listening. And that's a picture of my eight grandchildren whom I love dearly. So thank you very much for the invitation. And I really appreciate your time.
Thank you, Dr. Andy. That was a wonderful talk. We have a few questions for you. And we have people who have logged in from all over India. So this is a question which has come right from Kashmir. That's the absolute north end of our country. It says, can asthma be diagnosed in infants? Are you diagnosing asthma in infants?
That could be the subject of a whole new talk. But the question, of course, is what is meant by asthma? Now, for asthma, I mean a clinical diagnosis of wheeze, chest tightness, and breathlessness. And as we all know, there are many underlying causes of asthma, many different phenotypes. So the question really is, can we diagnose an eosinophilic airway phenotype responsive to steroids in preschool children? And there are good data from the infant study that a combination of allergic sensitization and a raised blood eosinophil count is predictive of a response to inhaled steroids. So again, this is something that needs to be validated in India, where I'm sure your normal range of eosinophils and your environment is different. But those things can be used. I think we should do that rather than give steroids in the tap water or give steroids to nobody in the preschool years.
What about in your group of patients? What percentage of patients are actually receiving biologicals?
It's very, very few. As I said, we've got about 30 or 40 on biologicals. As I say, most of them are, you find actually they're not doing the basics right. And I remember talking about biologicals in India, and a very experienced Indian physician rightly pointed out that for India, and for England for that matter, for India, getting the basics right is more important than any biologic that we have. It's always tempting to reach for something expensive and do something, but get the basics right first.
Thank you so much. Why is omalizumab not indicated if you have an IgE level above 1300?
And that's an extremely good question. And the answer is that's because that's what the manufacturer says. As I'm sure you're aware, the dose of omalizumab is determined by body weight and IgE level. Now, IgE is in adults, the IgE level is a poor biomarker of response. The better biomarkers are things like nitric oxide, exhaled nitric oxide, and blood eosinophil count. And in the TREAT study, where Professor Glani is looking to see whether, in fact, if you treat with omalizumab in those with higher IgEs, you may still get a response. We don't know the answer to that question, but your questioner is very shrewd and acute, because that there is no good reason, no evidence-based reason.
So if you have a patient who has higher IgE than 1300, I do understand that the product insert would say do not use it. But and if you have a patient who's not responding and we have looked at our basics, so you would say we cannot use it at all?
So in my country, if I want to use it outside that indication, I would need to put in a funding application for it, which is a long and time consuming. I would do so. I think in terms of choice, we would say, okay, if you need to get mepolizumab, you have to have a blood eosinophil count of more than 300. That's what the licensing authorities say, and an IgE within that range. So we would look and see, okay, which biologic is the child eligible for? If they are both eligible for both, then I would use omalizumab first, because there's more pediatric experience with it than mepolizumab. But if they're not eligible, if their IgE is 2,500, we would go for mepolizumab.
In the absence of having a facility to do laryngoscopy while exercising, can we diagnose vocal cord dysfunction, or now it's what it is called as exercise-induced laryngeal obstruction clinically?
Yes, I think we underuse mobile phone technology. I mean, every child and adult in the whole of the planet has at least one mobile phone. So if there's any doubt, you saw that video. I mean, anybody seeing that video would say that is not asthma. This young woman is stridulous. So get the family to make a video for you. And the clues, like it's starting during exercise. It's usually in the sort of high intensity, hard-working athletes who get it. Get a video of it. And I think there are many different contexts when we as pediatric pulmonologists should be using mobile phones more. Things like obstructive sleep apnea, is it true wheeze, all that sort of thing.
Absolutely. Yeah, because I recently had a patient whom we suspected an exercise-induced laryngeal obstruction. We took him on the treadmill. We tried to put a laryngoscope on us, but it just did not allow us to do it. So it was very difficult to do the test.
Yeah, I mean, older children, you may get away with it. I must say, if you asked me to exercise on a treadmill with something stuffed up my nose, you would probably get an extremely rude answer.
Yes. Okay. Thank you very much. That was very, very insightful. Yeah.
Dr. Indu,
yes,
may I ask one question?
Please, Dr. Shishir, go ahead.
Yeah. As far as omalizumab is concerned, how long is there, how many years experience is there in your institution with omalizumab? And what happens after stopping omalizumab? Is it a disease modifying agent or the asthma resurges again?
So very difficult questions. We've got 5 to 10 years experience with omalizumab, and we feel very comfortable with it. What we usually give a 16-week initial trial to see if there's any response. Obviously, if there's no response, we discontinue it and think again about the diagnosis and other factors. There are French data, an open label study that suggests that the longer you continue it, the better response you get. We find that we usually every few months have a discussion with the family about whether we try to discontinue it or not. And some patients we can successfully discontinue it, but others relapse. There aren't any guidelines or biomarkers that can predict successful discontinuation, at least as far as I'm aware. So it's a question of trying it and seeing it. And we have this discussion with the families. But it's an important question. This is an invasive and unpleasant treatment, as of course you know, sir, and one doesn't want to keep it going longer than is necessary.
Thank you.
Any other questions from the other panelists?
May I ask a question?
Yes, Dr. Subhash.
Sure. Just a note that do you exclude ABPA before starting omalizumab because you are taking the count of eosinophil as well as high IG? So is it a routine to exclude ABPA?
So I don't know why it is. The adults see ABPA and asthma. I think in 32 years, I've only once seen ABPA in a child with asthma. Omalizumab is in fact used in cystic fibrosis to treat ABPA if it's refractory. And all these children will have had a chest radiograph and a CT if there's any doubt. But I don't know whether things are different in India, but in children, at any rate, in the UK, ABPA is very, very rare. I mean, do you see that much in your clinic, sir?
Yeah.
In India, it's not so rare. Though it is not very rampant, but it is not so rare. We do get cases of ABPA, even from an Arman background also.
I would agree with that. We are seeing ABPA from time to time.
Yeah. I mean, since omalizumab has been used in CF to treat refractory ABPA, I would be comfortable using it in the presence of ABPA. But I would treat with steroids first on the basis that's the more conventional treatment, at least in the CF context. And then if they weren't responding, then I would go to omalizumab.
Yeah, we do see a lot of ABPA. I do agree with my other colleagues. Many a times, apart from steroids, we'll end up also giving them antifungals because they sometimes do not just respond to oral steroids. So I don't know, in this part of the world, we do see a lot of ABPA.
That is very interesting, and I wonder why. And I mean, it does underscore the need for studies in different contexts. Just because something happens or doesn't happen in London is no guide to what may be the case in India, and that is also one of the reasons why the biologic studies, the indications, needs to be worked out for India. So if there are young investigators listening, there's a topic to cut your teeth on. Thank you.
Thank you very much for your precious time and the patience that you exhibited to answer all our questions. And we definitely are enlightened with your answers. Thank you so much, Dr. Andy.
Thank you, and thank you again for your flexibility. As I say, I have a family health problem. I really do appreciate your flexibility and wish you a very successful rest of the meeting. Thank you very much indeed.
Thank you so much.
Thank you, sir.
So do we see much ABPA in our country? Many part of Tamil Nadu, we don't see much of ABPS. Really, very, very rare.
I am getting few cases of ABPA which has been diagnosed. I do not know. In last 1 year, I have seen, last 2 years, maybe 3 or 4 cases I have seen. Not too many, but those cases were refractory asthma with all device, adherence, everything basics has been taken care. And ultimately, they are all from poor socioeconomic setup.
Are those cases are merely due to a allergic fungal sensitization or a full-blown ABP?
They are more likely to be. One case was full-blown ABPA. 2 cases. One, I think, was sensitization to the fungus. And that child responded not only to steroids, but required voriconazole also.
I've also seen a couple of cases. Some were in children with cystic fibrosis. Of course, we do see a lot of ABPA and uncontrolled asthma. Many of them, I don't know. I think Dr. Menu Singh has one of the large case series of ABPA from North, and in fact, her percentage is what she's described is pretty high. And even in Mumbai, I don't know if it's got something to do with the weather, the humidity, more fungals, and people living in, kind of farm-like environments where, again, they may be more exposed to fungi. So maybe all that may, so if you look at the Western population where their weather is not so humid,
Humidity is much low.
Yeah, ABPA is much low. So I think in Mumbai, place like Mumbai, we do see because it's more humid here. So maybe in Chennai, it's not that humid. Maybe that may be the reason why you don't see so much. Just a thought.
Chennai is also humid.
Yeah.
Damp was also common in our country. So
Yes.
Yeah. So maybe that is one of the precipitating causes. I also think that could be one of the reasons.
Thank you so much, Dr. Bush, Dr. Indu, and all the panelists for contributing to the very interesting topic of what to do when asthma treatment is not working. So next, we have the much awaited session of Dr. Indu Khosla, who everybody knows throughout the country that she is one of the biggest pediatric pulmonologists in Mumbai. She has a special interest in flexible bronchoscopy. She has extensive work done in sleep medicine and mucociliary disorders. She has been the core faculty for the ATM modules and the national convener for NAPS module on sleep. She's also the international advisor to the Congress of International Pediatric Pulmonology, and she has established level 1 sleep lab for sleep disorders. And she's also attached with the Nanavati Super Specialty Hospital. So ma'am is going to take the much burning topic which has been discussed across multiple studies and as well as guidelines, that is the impact of pollution in childhood asthma. So I'm sure a lot of our viewers are waiting for ma'am to take the session. So ma'am, over to you.
Yeah, it's here. You can change it from here also.
Yeah, ma'am.
Thank you. At the outset, I would like to thank Lupine for giving me this opportunity on this platform to speak on a topic, air pollution and asthma. Honestly, I've never spoken on this topic before, so it gave me an opportunity to read about it, and I thank you for that. Because we keep learning, and this was a good learning experience for me. So a 7-year-old is brought by his mother with history of increased nocturnal cough and nasal block since 2 months. Was on inhalers and nasal corticosteroids for the last 6 months. So already this child was diagnosed as probably allergic rhinitis and asthma and was on therapy for the last 6 months. But in the last 2 months, his cough and the nasal blockade has become worse. There was a family history of asthma in the father, and he was better with the inhaled medication and nasal steroids. But in the last 2 months, something upset the balance, and his symptoms became worse. Compliance and adherence was checked, and they were both bang on. Mom said that ever since the coastal road, which is being constructed in Mumbai, ever since, I don't know since how long and how long it will go on, ever since the coastal road is being constructed and is right outside her window, the child's symptoms have become worse. Okay. So is there any evidence that air pollution can worsen respiratory symptoms and asthma? That's the first question I wish to answer. And any evidence that it can actually cause asthma in somebody who is not genetically predisposed to it? What are the causative pollutants, the air pollutants which cause these problems, and how do we manage? So I wish to answer these 4 questions in my presentation. So asthma is a very rampant disease. It affects globally about up to 18% of the population suffers from asthma. And prevalence in children ranges from 5 to 20% from various studies. We know it is a heterogeneous disorder with multifactorial etiology, genetic predisposition, but clearly we have not identified the genes which cause it. Environment plays a role. Behaviors, psychosomatic thoughts also would definitely play a role in the etiology of asthma. Now, traffic emission, that is traffic-related air pollution, is known to lead to worsening of existing respiratory symptoms, and it also increases the risk of new onset asthma. So they have estimated that the global annual asthma emergency room visits, a good 5 to 10 million, are due to the particulate matter, which is 2.5 microns or less. And we know that if your particulate matter is smaller, it can percolate deep into the airways. If it is 10 microns and above, it stays just in the upper respiratory area. So if you have a particulate matter which is 2.5 or less, it's going to go deep into your airways, and that is responsible for a good 5 to 10 million emergency visits. And ozone, which is of course required in the stratosphere as an ozone layer, which actually prevents the greenhouse gases and the global warming. But when you see ozone down on the earth, it is actually detrimental. And 9 to 23 million visits are actually due to the ozone, which we have. And these are responsible for the breakthrough exacerbations in asthma that we see. So how does air pollution impact us? It impacts the climate. We are all facing it. We are seeing floods. We are seeing, absence of rain. We are seeing many aspects of how air pollution is impacting us. It impacts individual health, public health, and it is known to increase both morbidity and mortality. So globally, 93% of children live with air pollution levels that are much higher than the WHO recommended levels. And that is a shocking statistics that 93% of children globally are living in an environment which is totally unhealthy for them. Air pollution causes 7 million premature deaths yearly. And of this, 92% are from the low and the middle income countries. So that is the shocking statistics that we have as the impact of air pollution on our health. So both ambient air pollution, which is outside our house, and household air pollution contribute to respiratory tract infections that resulted in more than 5 lakh deaths in children under the age of 5 in the year 2016. So these are your shocking statistics. And this is a world graph which looks at proportion of children under the age of 5 living in areas in which the WHO recommended air quality guidelines for particulate matter 2.5 microns are exceeded. And this was in 2016. And if you see India, it is in blue, and blue is about 98%. So almost whole of our country, we are living in a polluted area. which can probably impact many. I mean, I'm going to restrict myself to respiratory health, but air pollution impacts every organ in the body. Okay. So WHO came up with a summary statement which said prescribing clean air pollution and child health, and said prescribing clean air. And they said that the evidence is clear that air pollution has a devastating impact on children's health. And why? In 2022, India was the 8th most polluted country in the world. And if you see our capital city, it comes as a second rank as the most polluted city in the world. And why go far away? What happened to us in Mumbai this year, December, Jan? Our AQI was in red zone, and it kept on saying next 2 days also you will be red, in the red zone. And as clinicians, I'm sure all of you were struggling with children who are not responding to cough. So they may have had a viral infection, but their cough never went away. The adults were coughing, children were coughing, and they had persistent non-responding cough. They had exacerbations in their asthma. And I think it left us at a loss how to treat these coughing children. Trust me, it was terrible. Every child who walked in said the child is coughing from last 10 days, 15 days, nocturnal cough, not letting the parents sleep. And honestly, we had no answer for these coughing children. So it was Mumbai, we thought was not as bad as Delhi, but this time we really overtook Delhi. And our AQI, you see, these are different areas in Mumbai. The AQI was 309 on an average on one particular day, a Thursday in the month of Jan. And it was unbelievable. And the reasons speculated were the ocean winds, which once in every 2 to 3 days that the ocean took away the polluted air winds and took it out into the ocean. But for some climatic changes that we have witnessed, these oceanic winds were happening once in 10 to 12 days, causing the pollutants to be hanging on our city. I stay in Juhu area, and from my window, from my balcony, actually I can see mountains behind, and I couldn't see anything. For days. And then I didn't need the AQI to tell me how polluted it was. I used to look out. I said, oh God, it's going to be a terrible day today also. And I'll have a lot of coughing children. So that bad was the state of our city as well. Okay. So in 2022, the average AQI was 10 times more than what WHO recommends as guideline. Okay. So that was how bad our pollution is. Right. And for those, so you might say that nothing happened to me, but for those who are sensitized or who have sensitive lungs, it was a nightmare. And of course, we may not have symptoms today, but as I tell you, pollution is affecting every organ of our body. It is like settling in, and maybe not now, but little later we have inflammatory changes in our body because of this pollution. And so many of these diseases are because of pollution. So children are particularly vulnerable because if they are exposed even in utero, it is known to cause decreased lung volumes. So if a mother is exposed to even a tobacco smoke, or for that matter pollutants, or even for that matter even noise pollution, it affects the fetus, and it can definitely cause reduced lung volumes. A child who's born with small lungs will continue to have small lungs all his life, and they are obviously with small lungs, added viral infections, any other genetic history, they are going to have problems as they grow up. Children also have an outdoor play activity and therefore can again be exposed to pollutants. Newborns and infants who stay inside the house are more exposed to indoor pollutants. And there are a lot of indoor pollutants. We don't even realize what all we use and which can be actually a cause for the indoor pollution. Children have higher breathing rates compared to adults, and therefore they take in higher concentration of the pollutants. They are more mouth breathers. And if you breathe from the mouth, the filtering effect of the nose is gone. And therefore, again, you would take in more pollutants. Higher minute ventilation, ineffective nasal filtering capacity. And children have developing lungs, which are more vulnerable to inflammation and damage. Okay. They also have underdeveloped detoxification and antioxidant defense mechanisms, which again further cause more damage to their lungs. Children have shorter heights. When they have shorter heights, some amount of the pollutants have a higher concentration at ground level, that's ozone. And therefore, they are exposed to, again, higher pollutants. They also have a longer life to live. Adults have already finished at least half their life, so then they are going to carry this pollution right from an early age. We have seen our seniors who have lived 80 and 90 with good lungs. Our kids are now getting exposed to so much pollution and they have a longer life to live. So are we producing a generation of young COPDs? Time will tell us. Okay. Now, we have different kind of environmental pollutants. We have nitric oxide, sulfur dioxide, particulate matter from 2.5 to 10 microns, volatile organic compounds. Then we have wind factor. I'll come to the wind factor, which causes temperature gradients, and that can also impact the atmospheric pressure, can impact the sun, the humidity. And we know today, every day we have a new climate. It's raining somewhere in Madhya Pradesh. Last 2 days, it has been pouring out of nowhere. Okay, so all this change in humidity, precipitation can also impact your pollutants. So all of these can cause a lot of problems and can impact children's respiratory health adversely. So if you look at the ambient air pollutants, you could, as I mentioned, particulate matter from 2.5 to 10, ultrafine, and 2.5 will actually go down into the lungs, whereas 10 and above will stay on the upper airways. They come basically from fuel, vehicles, factories, dust and construction work. So Mumbai, I think, got delivered before it was completely ready. So it's completely under construction, and many cities in this country are in that state. So we have so much of dust and construction, which is causing this particulate matter to increase and causing damage to our lungs and even our other organs. Your ozone, again, comes from similar sources, your fuel, chemical reactions between oxides of nitrogen and volatile organic compounds, which are emitted from natural sources and other human activities, which I will tell you. Carbon monoxide, nitrogen oxide, that's nitric oxide, nitrous oxide, sulfur oxide, lead, mercury, etc., which can come from various industries, which can also pollute the environment. When it comes to household pollutants, again, you have all these chemicals like particulate matter, carbon monoxide, nitric oxide, secondhand tobacco smoke, proven to cause exacerbation of asthma, even precipitation of asthma. And all this can come from, we use gas pipelines, but much part of our country still uses fuel for combustion for cooking. And mosquito repellents and the all that we use in our day-to-day life also have some amount of pollutants which actually go down our lungs. We use pesticides, we use perfumes, we use so many of these sprays. All of this come under the category of volatile compounds, and they can also affect our respiratory health. Then we may want to renovate a house. We use paints, we use benzene, foam, etc. All of them are also chemicals which come under the category of volatile organic compounds. So if you look at the total, it's called TVOC, total volatile organic compounds. The list is quite big, and more than 60 products, right from detergents that we use to perfumes that we use, sometimes the kachuas that we use, are all responsible, are actually pollutants, right? And they are responsible for affecting our lung health. Okay. Apart from that, we may have pets, dust mites, cockroaches, rodents, molds. They add fuel to the fire. Okay. So this is the list of indoor air pollutants, right? So I just mentioned about tobacco smoke, which is a proven secondhand smoke can affect the child in utero as well as postnatally. Now, I wanted to talk to you something about inversion definition. Okay. Now, you must have all seen this, that in winter months, okay, this typically occurs in winter months where the pollutants get trapped lower down. So there is cold air and this warm air goes up, and because the cold air cannot rise up, the pollutants which are there in the cold air stay trapped below. And therefore, this can even worsen. This is called the inversion factor, which can worsen pollution, right? All right. And I think I've mentioned age at exposure, younger the kid, more likely that you can have problem, lower socioeconomic strata, children who are malnourished, or even the Asian countries where there is more pollution are more at risk. Lower genetic polymorphism can also affect the adverse effects of pollution. And if you are allergic on the top of it, you will have more problems. So you have triggers which cause you to get more, you will manifest with more atopy or more asthma because you have an underlying genetic defect which predisposes you to atopy. I'm going to not go into the detail of this slide. This is the pathophysiology, which basically results in small airway obstruction, alveolar wall destruction, release of neutrophil elastases, and metalloproteins, all of this which cause mucus hypersecretion. And this is the pathophysiology of how all these pollutants keep on causing lung damage, and it causes remodeling, fibrosis, and destruction of the alveolar walls. All right. So what is AQI? So it is an index which reports air quality. The higher the AQI, more polluted is the air, and more is the adverse impact on health. Okay. The Environmental Protection Agency calculates the AQI is based on 5 air pollutants, which is the ground level layer of ozone, particulate matter size from 2.5 to 10, carbon monoxide levels, sulfur dioxide levels, and nitrogen dioxide levels. Okay. And it depends on how much particulate matter is suspended. They do a multi-gas sampling. They look at the wind speed. They look at the temperature inversion profile. And all these things are taken into account when you measure the AQI, right? And based on that, they would tell you a value. So it's a complex calculation. If your value is of the AQI is between 0 and 50, and I hope and pray that we reach there someday, air quality is satisfactory and there is no air pollution and poses little risk. If you have a value of 51 to 100, it is still acceptable. Okay, but it may be at risk for some people who are unusually sensitive to air pollution. But if you start going above 100, 101 to 150, it can have adverse health effects to general public, even if you're not very sensitive. If you cross 150, you may have worse effects and serious health consequences. And of course, if you go higher to more than 200, it's a health alert. And a lot of advisories come out if your AQI is more than 200. Okay. And more than 300 is actually a health warning. How many of us did realize that in December and Jan, we were actually sitting on a health warning? We were all out doing whatever we had to do, running to work, catching the train, or wherever going and doing what we wanted to do without even realizing what we were actually getting exposed to, right? So, sorry. I'm so sorry. Why is it going ahead? I needed to go back. It's going ahead. This one? No, it's going ahead. Thank you so much. Okay. Fine. And you know what? Our standards are different. So it is relaxed compared to the US. And I don't know why. And I don't know why we should have this disparity. So in US, the standard for the environmental pollution is 35 micrograms for your AQI, and and whereas for India, 60 is acceptable. I don't know why this disparity. All right. So what does it cause to our body? How does it impact us? Right. So it will cause respiratory infections. It can cause antenatal problems in children. It can also, if you are exposed to pollutants, these pollutants can piggy bank on bacteria and actually cause pneumonias. And we did see a lot of pneumonias this year. after the month of December, Jan, we had pollution. We had probably see a lot of pneumonias. It can, if it affects the lungs antenatally, it can actually cause smaller lungs, reduce the lung volume. It can affect the growth of the lung. The lungs continue to grow till the age of 20. The maximum growth occurs in the first 7 to 8 years. So if you have exposure to all these pollutants which I've mentioned, it can actually impact the growth of the lung. Okay, and it can of course precipitate asthma and cause exacerbation of asthma. In adults, if you continue to have exposure to tobacco smoke, which is also a known pollutant, we know lung cancer is a proven complication. Allergies, allergic rhinitis, hay fever can occur. Lung function can get affected, and this is what it can cause in adults. Now, let's look at some articles to say what I have just mentioned. Does it hold any water? Is there any evidence to back it up? So there was this study which looked at the burden of childhood diseases due to pollution. So this was a study which was recently published in 2019, and it showed that there is emerging evidence to suggest that air pollution may contribute to childhood asthma development. And we estimated that the burden of incident childhood asthma that may be attributable to all these pollutants is whatever the burden that we are seeing is because of these pollutants. And this was a study from Europe where the pollution is much less than in our country. So where do we stand? Okay. And they said a significant proportion of childhood asthma may be attributable to the outdoor air pollution. And these cases could be prevented if we modify our environment and we reduce the pollution that we currently have. So they said that our estimates underline an urgent need to reduce children's exposure to air pollution was their recommendation of their study. There was another study which is called the ESCAPE study. It was a European study of cohorts for effects of air pollution. The aim of the study was to study the association between residential exposure to air pollution and lung function in 5 European birth cohorts with a standardized exposure. So what they did was they followed up these children from birth to the age of 6 to 8 years. They looked at the air pollutants which these children were exposed at birth, and they looked at what they were exposed at the age of 6 to 8 years, and then they did the lung function test. And what they found that exposure to air pollution, which increased over a period of time, resulted in reduced lung function in school children. Okay. Now looking at the traffic related air pollution, and this is another study which was a meta-analysis and a systematic review of 27 studies from Jan 2000 to 2019. And it investigated the association between exposure to traffic-related air pollution and the development of childhood asthma. And they found that this meta-analysis provided evidence for a positive correlation, that more the traffic, more the pollution, and more the exposure, higher the risk of childhood asthma development. And the results also indicated that all of these were implicated: particulate matter 2.5, nitric oxide, benzene, total volatile organic compounds will increase the risk of development of childhood asthma. So these were the forest graphs from this study, which analyzed each of these pollutants separately, and each of them were positively related with the development of asthma. So whether this was a forest graph with particulate matter, this was a forest graph with benzene exposure, and this was a forest graph with nitric oxide, and this was of the volatile organic compounds, which we use without even thinking. In our house, we use all the pesticides and everything possible, the perfumes and whatnot. All of them had a higher risk of developing, their odds ratio was above 1, and therefore it was associated with risk of developing asthma. And I think this is fine for statistics, but the proof of the pudding is in its eating, which was a very interesting phrase, which was coined by William Candid. What happened in the COVID-19 lockdown? And we are all witness to this. COVID-19 lockdown, did it impact our children in a positive way? Did it reduce the recurrent wheezing and asthma? And I don't really, need to ask anybody, and everybody said we hardly saw children who were wheezing or who were coughing. So this was a questionnaire-based study, and it was carried out in Spain. I don't know what will happen if we do this study in India, and I implore upon Lupine to do such studies in India and bring about a revolution to decrease the air pollution that we have. 475 asthmatics in preschool visitors, average age was around 5.5 or 6, were enrolled using a questionnaire. And this was done in Spain, where what was the conclusion? That most children with recurrent wheezing and asthma remain well controlled from their underlying disease and did not modify or did not their maintenance treatment. This happened in the lockdown, and we were sitting idle as pediatricians, and everybody over here will agree to that. And it was not that they were scared to come, because they were online consults were on, right? It was actually that they really did. And many of them stopped their inhalers, and they were still doing very well. And the moment everything opened, everything came back. All right. Another study, which was published in 2021, which looked at effects of COVID-19 pandemic and lockdown on symptom control in preschool children with recurrent wheezing. Again, this study concluded that during the national lockdown, there was a reduction of the respiratory symptoms, medication use for exacerbations, and even the use of healthcare resources. Then read the last line. The trend reversed when the lockdown restrictions were eased. So this is, I think, the proof lies in eating the pudding. And there is no two things about it, that what we are currently, where we are living, our earth, so-called Mother Earth, which we have kind of, destroyed with so much of pollution, right? So how should you clinicians approach a patient who comes to you at your clinic? What history should we take? We normally take history, family history of asthma hai ki nahi, raat ko khasi hoti hai ki nahi, fever hai ki nahi. But now we need to add to our history. We need to find out, is there any ambient air pollution in the house? We do ask, but we ask very superficially. We need to find out outdoor air pollution as well. We always, when we wrote the guidelines for the asthma training module for the country, there was this very nice statement which came. The grandmother asked, should we change our address because my child is getting too much wheezing? So the answer said, no, don't change your address. Change your home, inside environment, whatever. But looking at all this data, the outdoor pollution is equally responsible, if not worse, in causing the problems in our children. So the question that we need to ask is, how far is your home or school located from the main road? So there was this very interesting study. For the want of time, I did not put it. So they looked at people living 200 meters inside and people who are living on the main road. And they found there was a difference in their respiratory health. So you should ask, how far is your home and school located from the main road? I wonder how many of us have a choice to change our homes in this mad city of the cost of land. But if you are buying a new house, this should be in your mind. And how does your child travel to school? Bus, AC car, auto rickshaw, two-wheeler. If he's going in an auto rickshaw, he's going to get exposed to the outdoor pollution. And many parents come and tell us, "Aise to acha tha, wo auto mein yahan se wahan gaya, uske baad khasi shuru ho gaya." And we always say, it doesn't happen like this. We always actually disregard what they say, but that is not true. Where does the child play in the evening? Any construction work? Well, I live in Mumbai. The whole city is under construction. Any garbage burning dump close to your home, any farm fields with burning of harvest. You've heard in the north when they harvest the wheat, what is left behind? The wheat shack, I don't know what's exactly called, but they burn it, right? So that itself causes a lot of air pollution. Who will get the labor to actually invest in that much money to actually remove it? So you just burn it off. So that can also cause pollution. Flowering trees blow pollen. And pollutants add on to pollen, and together they make your respiratory symptoms worse. Okay. Does your child have aggravation of symptoms like Diwali, Holi, Ganesh, Chaturthi, and all the firework display? Obviously, they're also chemicals and they add on to the problem. Indoor. Are you using what is the fuel you're using to cook? Is there a smoker in the family? And very quickly the answer will come, I smoke outside the house. Okay, that does not work. 8 hours plus the nicotine is going to be in your mouth and it's going to affect your child. Does the household use mosquito repellents? Who does not? We have to choose between dengue and respiratory health. Liquid dispensers, insecticide sprays. Are there any agarbatti dhoops used at home? Any renovation in your house, and type of furniture, type of wood, etc. So all this should be a part of your history. then you can manage these children and probably advise them on prevention of asthma. Look at the modifiable risk factors in this, what you can in this whole thing. There's few things that you can modify. Maybe you should modify that. Look at your indoor pollutants, outdoor pollutants, allergens, and child must avoid the allergens, irritants, and trigger related things which trigger their asthma. And if it's a very heavily polluted day, you must restrict their outdoor activities on that day. So it's an advisory. People who go running, biking, if it's a heavily polluted day, they're advised to stay at home on those days. And N95 masks are the only good masks that can be used. I don't know how much it helped in COVID, but it'll definitely help in reducing the particulate matter going down to your lungs if you use the N95 mask. Ask them to use it when they're going to a polluted environment. Smoking is an absolute no-no. If you have a dust, molds, dust, and dust mite in your house, look at that. Ventilation, use of air purifiers. Many patients come and ask you, I've put an air purifier in my house. Will that help my child? Can I buy an air purifier? So there is not very limited data on use of air purifiers. I mean, even if you use it, there are certain prerequisites, the HEPA filter, the air cycle changes that should occur with an air purifier. But again, what happens if the child goes out? What happens there? So, and how long are you going to live in an environment with air purifiers? Whatever data we have is for a very small study. So we need more data. And I don't think this is an answer. It's a stopgap arrangement to use air purifiers. Mosquito coils are a no-no. Agarbattis, if you can avoid, nothing like it. But it's only for those who are sensitive. There may be people at home who use agarbatti all the time and nothing happens to them. But people who are sensitive to it can have a problem. Look at your fuel for cooking, and of course, smoking and secondhand smoke. All right. Management are standard. I will not go into the management of asthma because I just wanted to highlight the effects of pollution on the lungs. You may have to investigate measures of inflammation and functional assessment, and then you treat as per your GINA guidelines or any guidelines, the NICE guidelines, the asthma training module guidelines. So one can looking at doing an FeNO, which is a surrogate marker of eosinophilic inflammation of the airways. And it also will tell you that it is a corticosteroid sensitive bronchial asthma. Eosinophil count is a plus minus in our country because it can be raised because of many other reasons, right? And one can look at doing spirometry to look at assessment of and diagnosis of asthma, impulse oscillometry, still a long way to go, but can be done in smaller children who cannot cooperate to do a spirometry. We do not have too much of normative data at this point of time, but in times to come, we will have normative data, and probably we can use this tool for obstructive airway disease. And these are your standard guidelines from GINA, where you manage your under 5 or 6 to 11-year-olds. So I'd like to conclude that rising ambient air pollution, household pollution is adding to the burden of allergic diseases, asthma, mortality, and morbidity. We should not forget our household air pollution, which is also a cause of disability-adjusted life years. And there were studies from Southeast Asia, and this is the third leading cause of disability-adjusted life years globally. Children are more vulnerable, and I've highlighted the reasons why they are more vulnerable to harmful effects of pollution. We need urgent steps. We need, I would say, a political will to work here. And I think as medical practitioners, I think we need to create a movement if we can. And maybe the pharma industry should also think about this to curtail, to create a movement to curtail the harmful effects of pollution. It's a need of the hour. And we need to take this at a personal level, at a community level, at whatever level we can take. Thank you so much. You can always.
Thank you so much, Doctor. Just to give her a breather, let me update you. I was just going through our Lupine facility, and we are among Indian pharmaceutical companies. We have a score of 7 on international sustainability rating systems. And not only that, but if you see our greenhouse emissions, energy consumption and conservation policies, water and waste management policies, I think we are a peg above anybody in the industry and strive to get better. Talking about AQI, especially outdoor, your questionnaire still will help for the indoor ones, but we can probably provide you a pin code based AQI index as an app on your phone. So it's not when you check your PIN code in your clinic, but you can write in a PIN code of where the patient stays, and we could give a real-time AQI. We can give a predictive AQI, and we can give a historical AQI. So we would be more than happy to extend that to anybody who's keen to understand this better. I know it's not long enough, but I again hand it over to you to take it ahead, ma'am.
Are there any questions? If you can get the other panelists on the view, then maybe if they have any questions, I would be happy to answer. Any questions from here?
Not really. One question which is very practical implication, that most of the, as you have said, most of the parents say, I don't smoke inside the house, I smoke in the terrace or in the garden or any other places. So what is your advice? How long the father or mother should not come in contact with the child after smoking a cigarette?
So they say 8 hours. The effect of smoke stays in the father's mouth when he's a child. So I don't start there. I tell them it's bad for you first. You stop smoking. You will die of cancer. You will not be able to. I actually scare them. I said, तुम मर जाओगे कैंसर से. तुम्हारे बच्चे को तो बड़ा होते हुए देखोगे कैसे? So I think that's the way. I mean, I would, and I tell them that there is no. If you give them an option, कि 8 hours के बाद आप आके अंदर, if you can come home, they will wait for that 8 hours and come home. That also they will do. So I don't think we should give them options here. And especially if you have a pregnant woman at home, it's absolutely detrimental. What worries me most is today young girls are smoking when young men are smoking. It's terrible what they will do to their pregnancies. We will have babies who are born IUGR in small lungs. It's going to be very difficult.
And one primary prevention of asthma is not smoking during pregnancy.
Absolutely.
That is a documented one.
Yeah, that and breastfeeding. They are two documented preventions. Okay. If there is no more questions, then maybe we'll just proceed with our next panel discussion. I don't need an introduction slide to introduce this panel. To me, they're all eminent pulmonologists and dear friends. Dr. Shishir Modak, who has recently updated our asthma training guidelines, to me is a thorough clinician. And if you give him a scientific activity, the completeness and the thoroughness with which he does it is remarkable. So that's something which I learned from him. And he's going to moderate our today's session. Dr. Prakash Vaidya, his name is very apt for him. This I may have used it in the past to describe him. He's a Vaidya, means a physician. Prakash means he emits light wherever he goes. And that's what he is to me, because he always is a guiding force for me, a friend, a philosopher, and a guide. And he's one of our eminent panelists today. Dr. Subhashish, what do I say about you? Learned a lot from him in the sense, again, like Shishir, absolutely thorough in his work. A man of commitment. You give him a work and you can close your eyes, it will be done. Absolutely thorough in his knowledge and an extremely superb human being. Dr. Sarad Balaji. He's my teacher. He looks the youngest of the lot, but I have learned bronchoscopy from him. I have learned how to be cool in one of the most serious patients who may be there, and still he will manage to do his bronchoscopy and come out. He will do so much work in so much little time. It's amazing. And of course, totally updated. Again, my go-to person if I'm stuck with an odd case. So this is the panel for you today. I hand it over to you, Dr. Shishir, to take this forward.
Thank you, Indu, for so many kind words. And I start sharing my screen. Are you able to see my slides?
Yes, sir.
Yeah. So at the outset, I would like to thank Lupine for giving me this opportunity to be a moderator here for the important panel discussion. And it's my pleasure to be here in front of you on World Asthma Day to discuss pediatric asthma management. but the word need gap is important. So we are up till now in all the modules and guidelines, we discuss the ideal management. But here today, we will mainly discuss what is happening in day-to-day practice on the ground. So what is the ground reality versus the guidelines? So I have a very eminent faculty, stalwarts from all the corners of the country. Dr. Sarath Balaji is from Chennai, Dr. Subhash is from Kolkata, and Dr. Prakash Vaidya from Mumbai, and I am from Pune. So here we go. I am aware that we are late, and please pardon me if I keep you hungry for next 40 to 45 minutes. So asthma is a common chronic respiratory disorder in children, and all age groups are affected. It is common in preschoolers also. GINA 22 guidelines are available for ready reference to the practitioners that how they should practice. But let us now discuss the gaps between the actual management done in practice and the international guidelines. Do we practice the guidelines, whatever is recommended in the guidelines? So that we'll discuss. And we'll discuss this in different age groups. So under 5 years, 6 to 11 years, and about 12 years. So this need gap in pediatric asthma management exists at all levels. So it is at the diagnosis of asthma, it is in the acceptance of diagnosis, management of asthma, monitoring and follow-up, and even in new research domain. So let's see these two children. Here is Ayan, who is a 2-year boy who comes with cough, wheezing episodes since joining a creche 8 months ago, each lasting initially for 5 to 6 days and once in 2 months. But now since last 2 months, symptoms are more prolonged and nocturnal. He is not completely asymptomatic in between 2 episodes, and there is no history of atopy in the child, nor there is a family history also. So frequent symptoms, recurrent symptoms, but no family history and no history of allergy. On the other hand, Sia, she is a 3-year-old girl with recurrent cough, wheezing for last 1 year, usually not associated with fever, 6 to 7 episodes per year, and lasting for about more than 14 days or so. So they are prolonged episodes. Coughs, especially on running, crying, and cough does not settle completely even if in between the episodes. So Sia had eczemas in the past, and history of allergic rhinitis is there in the father. Now I asked Dr. Prakash that what questions would you like to ask the parents when such recurrent wheezes come to you?
Thank you, Shishir. So we all know that history is very important, but that is something we somehow then spend the least time on. So here, everything is depending on the history. We must first profile the type of cough that the child has. So what would I ask in the profile? I would like to know how long the cough is going on. What is the timing? Is there any nocturnal aggravation? That's a real giveaway for a cough that is due to airway problems. Is it dry or wet? Now you will ask me how a small child can be told that they don't expect a rate. So how can you make out wet cough? But parents typically can make out that there is a gurgling noise that comes, and sometimes the child does bring out after coughing a greenish sputum. So you do get a pointer that many parents are able to make out wet cough. Whereas with preschool visits, very important to know whether the cough is dry or wet. It changes our approach completely. Then we would like to know whether the cough is there any kind of diurnal variation, as we mentioned, whether it's worse at night, and whether importantly, what are the trigger factors? Is it triggered off by exercise? And how does a child exercise, whether it's by running, crying, laughing? Is the cough worse? And the other thing is that whether it's worse on exposure to any smoke, and importantly, whether there is any cold with the cough, or it just cough alone. Is there any fever? The presence of fever really tells you that it's a viral triggered cough. Then while you're profiling the cough, you would also ask the history of the family background, meaning does the child have any personal allergies like say allergic rhinitis like symptoms, or skin allergies, atopic eczema, or even allergic conjunctivitis, and if there is a family history of allergy in the immediate family members. So that also is important. The other thing is that most of us are prone to we do give bronchodilators, but what we are interested in knowing is what is the response to this treatment? How does the cough respond to this treatment? So cough that responds to bronchodilators well is typically going to be a cough of a child with an airway that is sensitive and that may have a reversible airway obstruction. And of course, what is the child in between two symptoms? Is he completely all right? Now, most parents will say, my child is coughing from the day he joined school. But when you actually dissect out and you see what's happening, there are some good days and then there is one more episode. So we need to really delineate that and get a complete history. So I think overall, this is what it is, coupled with, of course, with the background of the duty of every pediatrician to take a proper growth chart of the child. So in a child growing well, we should obviously chart that and also have the profile of the cough as I mentioned.
Thank you, Prakash. You have very nicely covered all the questions which a pediatrician need to ask. One point I would like to highlight is differentiate from other respiratory noises, because we are talking about cough and wheezing. So this wheezing is whether it is really wheezing or is the noise coming from, say, upper respiratory tract like a stridor or snoring or snorting. So that needs to be differentiated, and all other points Prakash has nicely covered. So how do you position Ayan and Sia in such cases? So you have known the symptoms, mother has replied to your questions, and how do you position these two children?
So basically, in the past, it was a very simplistic kind of approach that we used to say episodic wheeze, where wheeze was happening only with certain viral episodes, and other was a multi-trigger wheeze. And we used to say multi-trigger wheeze was asthma, episodic wheeze was not asthma. But life did not turn out to be so simple, because these two categories became very, very interchangeable. I mean, people would go from one category to the other. So now we have been off late following these beautiful GINA boxes, where they have a probability of asthma based on the child's symptoms. So very quite simply, what do we look for? I think Shishir, you would, basically we would look for how long the cough lasts. If it lasts for less than 10 days or whether it's more than 10 days, that is the other extreme. How many episodes per year, and how is the child between episodes? If the child is fine between episodes, cough is not very long lasting and not more than 2 to 3 episodes per year, this is the category where there is the least likelihood of asthma. On the other hand, no prizes for guessing that if there is something completely opposite, cough lasting for more than 10 days, multiple episodes per year, often symptomatic between episodes, that he may be fine, but he may have some nocturnal cough, or he is otherwise fine, but he has cough only on running or playing. And one more thing that is a red flag that has been added in this fourth box is the personal history of atopy. Is there any likelihood of airway sensitization? Is there likelihood of aero allergy, or is there a likelihood of food allergy, family history of asthma, or a personal history of allergy? And the second box is in between the two, where the symptoms may be, I mean, it's not so clearly defined. There is often no history of allergy, but the episodes are somewhere in between the two. The duration is between the two, and occasional symptoms. So that way we can have a probability index. In the first box, rare asthma. In the last box, likely asthma. Middle box, some of them may have. But again, the boxes, the people may drift from one box to another. These are not watertight compartments.
Absolutely. So that's why these arrows are shown, which are bidirectional arrows. They are not watertight compartments, and this symptom pattern may change over a period of years or months. So our children, Ayan fits in the middle box because he doesn't have his family history and history of atopy, whereas Sia, she fits in the third box. Now, with this symptom pattern, how do you plan the treatment for Ayan and Sia? Dr. Subhashish, can you take up this?
Yeah, now both of them have very similar age groups. One is 2 years, Ayan is 2 years, and Sia is 3 years. So they are preschool visor. And they have very frequent symptoms, and Ayan is having more frequent symptoms since last 2 months. They are having a prolonged symptom, which is staying there for at least for a week or more. And they are having interval symptoms as well, because in between the serious episodes, they are having some amount of cough. Whereas Sia is having atopic history and father is suffering from allergic rhinitis. So Sia is more or less in the garden variety. If you can say, it is almost a garden variety of asthma patients as the present. But as these children are preschool visor, we will not qualify them as an asthmatic. First, I will rule out, is there any asthma mimics in them, or not, like any aspiration syndrome or any foreign body history of choking or foreign body aspiration or any other things that can be there. But if that is not there, and especially in case of Ayan, why the cough has increased for last two months, because earlier the coughs were not so frequent, but last 2 months, iron is getting more and more frequent episodes. So I will exclude whether there is any foreign body aspiration in iron or not. But in both the cases, I will not start a treatment of asthma. I will not qualify them as an asthmatic and start the treatment. Rather, we will start a low dose of trial of inhaled corticosteroid, because we want to be sure, because these children may not be a true asthmatic. And as you have seen in the earlier slide, they may change the compartment with time. So we will start budesonide, which is the most commonly used molecule in pediatric age group asthma. And had we got the 50 microgram of budesonide, I would have started 50 in the morning, 50 at night. But here in our country, only 100 is available. So I will start budesonide 100 microgram for 3 months. That is a inhaled corticosteroid trial. And if the child improves, then also I will stop the treatment. If the child does not improve by 6 to 8 weeks, then also I will stop the treatment. I will not escalate the treatment. I will not increase the dose. I will not add anything. If the child is not responding, I will revise my diagnosis. I will go for further more workup, that whether it is something different, whether it is a cystic fibrosis, primary ciliary dyskinesia, or immunodeficiency, or any other thing, or foreign body, or congenital heart disease, or congenital lung problems. If the child has responded well, still I will not continue to give a trial. If I stop, if the symptoms recur shortly, within a month or 2 weeks, or frequent attack starts happening after withdrawing the inhaled corticosteroid, then I will start inhaled corticosteroid. I will counsel the family. I will start inhaled corticosteroid still in the lower dose for a longer period of time. And in these two cases, probably SIA will require a longer period of budesonide. As per the child is, the difference between iron and SIA is that both are having frequent symptoms, both are having interval symptoms, but SIA is having atopic marker, SIA is having a family history of allergic rhinitis.
And in case of SIA, why do you want to stop the treatment abruptly after 3 months? And why not to continue as we do in older children?
Yeah, because I like to see whether this is a natural remission or not. Because any chronic disease, there is a tendency of natural remission. So withdrawing, as these children are preschool visa, before qualifying them as an asthmatic, I must be very sure that I am not missing something. And yes, the ICS is going to give the child a definite benefit. So
absolutely.
Even SIA has improved, I will stop the treatment.
Yeah. So in younger children, in children below 5 years, there is a high chance of natural remission. So we should give that benefit of doubt to the child, and why to load unnecessarily with inhaled steroids for 6 months or a year if it is not necessary. So that's why we should give a trial of stopping abruptly without tapering after 3 months. Thank you, Dr. Subhashish. Now, in your opinion, do practitioners assess probability of asthma properly and start this ICS trial as per guidelines? We have seen what ideally should be done, but what is happening in practice? Subhashish?
Unfortunately, in my practical experience, I can tell in Calcutta, in last 5 years, from 2018 probably, or 19, the probability of GINA has come in practice. I have seen only 2 prescriptions from the pediatricians in last 5 to 7 years who has written in the diagnosis that moderate probability of asthma or high probability of asthma, and started the therapy according to the probability of asthma. So probably the physician or the pediatrician has not taken a proper history, and they have not given actual weightage to the pillars of the diagnosis, like how many days the symptoms are persisting, whether there are any interval symptom, and whether there are any atopic markers, there is any family history of asthma or not. The main constraint for the general pediatrician is the time, because in a very busy clinic, it is difficult to assess a preschool visa in this line, and probably general pediatricians are yet to conceive this concept very well and translate that into their practice.
Dr. Prakash, would you like to add something?
Yeah, I agree with Subhashish. 2 things. One is that people hardly ever do a trial of ICS. I mean, that concept of trial of ICS needs to be much more understood and practiced. People would, I mean, there are people who would start, and unfortunately what happens is for many practicing doctors, the inhaled therapy is nebulized therapy. It is not metered dose inhaler at all. So they tend to just give nebulization, maybe with salbutamol and levosalbutamol and ipratropium, that is one of the brands is Duolin, or they give it with budesonide for a while and they forget about it. So it's like a fill it, forget it story. The concept of an ICS trial to be given properly for a minimum period of 6 weeks has yet to really be understood and accepted by the majority. And the second thing is, as I said, people tend to go by nebulization and do it only for a short time and not for a long enough period. So that's why I think this is really a need gap which has to be addressed, so that more and more preschool visitors will benefit by a proper trial.
Absolutely. So
And
usual story.
one point I'd like to add, Dr. Shishir. In our office practice, the children who are coming with wheeze, of which 80% are preschool visitors.
Absolutely.
Absolutely. True asthma is so uncommon.
Coming to investigations, do under 5 years need investigation? Do you investigate children under 5 years? And in which, obviously, we don't investigate all the children. So how do you decide which children will be investigated? Dr. Sarath?
So, Haiza, as far as an under 5 users are concerned, there are so many differential diagnoses we have in our mind. So first of all, we need to see whether that recurrent cough fits into an under 5 years. That recurrent noisy breathing fits into an under 5 user, and their response to bronchodilator really mean that we are dealing with the under 5 user. Point number 1, we need to, before starting inhaler therapy, that is your budesonide 100 microgram per day for a trial of 6 weeks, yes, we can start. But before that, we need to make sure that we are dealing with a case of an under 5 user. For that, we need to rule out certain red flags. What are all those red flags? Asthma, particularly even an under 5 user, unlikely to occur in a children of less than 1 year, least likely to occur in a case of 6 months of age. It can be a case of recurrent bronchiolitis, or due to a viral induced visa, or it can be a bronchiolitis, which can be a manifestation of a mucociliary disease like your cystic fibrosis or primary ciliary dyskinesia, which we have been increasingly being diagnosed after incorporating your genetics in our as a frontline investigation. So asthma as a disease of reactive airway disease unlikely to occur in children less than 1 year. Point number 1. And it is always associated with bilateral bronchoconstriction. So when you have a focal finding, it can be due to an intraluminal foreign body, or it can be due to an intraluminal tumor, or it can be due to a focal bronchomalacia, or it can be due to a vascular ring. So if you hear wheeze in one particular segment, or in one part of the lung, or in one lung, it is unlikely to be a case of under 5 user. Second point, there should be a response to bronchodilator. If there is no response to bronchodilator, again it is a fixed intraluminal or extraluminal obstruction, unlikely to be a case of wheeze, and it is not going to require your inhaler therapies. Asthma again is a disease of bronchoinflammation and bronchoconstriction, and it is characterized by dry cough because of the stimulation of cough receptors in your major airway, such as your in bronchus. That's why it is not associated with any mucus production or something, as a result of which unlikely to have a wet productive cough in a wheezer. Either it is an under 5 wheezer or more than, or a typical asthma which occurs in children more than 6 years. So a wet productive cough is unlikely to be an asthma. Again, it is a disease of inflammation and not infection, as a result of which when we get constitutional symptoms like fever and poor weight gain, think in terms of an immunodeficiency, cystic fibrosis, PCD, or in a country like India, TB. Again, constitutional symptoms rule out asthma as a primary diagnosis. Again, clubbing. Clubbing indicates chronic hypoxia, unlikely to be a case of an asthma. And again, multi-system involvement. But here, multi-system involvement and involvement of upper and lower airways such as allergic rhinitis, conjunctivitis, eczema can occur. But it is usually allergy related and not something else like an oily stools or recurrent abdominal pain, which occurs in a case of cystic fibrosis.
Yeah, so
and
all the
again,
points are well taken. And so we move ahead. So all the delegates should very nicely read this slide and remember it, that when the asthma is unlikely, you may investigate the children. Now, which are the common asthma mimics you see in practice, Dr. Sarath?
Whether I am seeing a case of a recurrent cough or recurrent breathlessness, which is responding to a bronchodilator or not responding to a bronchodilator, that is the question. As a pediatrician, the most common diagnosis is whether the child is associated with failure to thrive or without failure to thrive. If the child is associated with failure to thrive, I will think in terms of a mucociliary dysfunctions like cystic fibrosis, PCD or immunodeficiency, or in fact TB. If I don't see any failure to thrive, it can be due to a structural disease such as your bronchomalacia or tracheomalacia, or an inhaled or a retained foreign body, or else it can be due to a vascular ring. And a large massive heart can compress your heart, particularly your left bronchus, leading to bronchomalacia. And again, a bronchogenic cyst can cause recurrent fixed obstruction of left main bronchus or right main bronchus indeed. So whether it is most commonly, we will see one is retained foreign body, another is airway anomalies such as tracheobronchiomalacia, which we see in our usual practice in pediatrics.
So these conditions should always be kept in mind before starting trial of ICS or before labeling the child with asthma. And younger the age, there are more chances of some alternative diagnosis. Yeah. Now, objective tests like spirometry are usually not possible below 5 years of age. However, it is said that as a good objective test in children under 5 years, impulse oscillometry can be considered. So, Dr. Sarath, what is your experience? Do you do impulse oscillometry? And if at all you do, how many times you advise?
Even right now, we have been incorporating impulse oscillometry for the past 1 month, sir, in our department. And I need to thank Lupine for this opportunity, because we are going to do impulse oscillometry once in a week for many children. And we have been trying our hand with respect to learning the techniques of impulse oscillometry. And we need to learn by ourselves, and we need to incorporate these things as of now. We started incorporating it. So once we get an idea about that R5, R19, everything, we will be in a position to tell about the usefulness of impulse oscillometry. As of now, as far as the studies are concerned, definitely between 3 to 6 years of age group, in which where PFT cannot be done, that reversibility with respect to bronchodilator can going to give you a clue.
Dr. Subhasis, your experience, or in Kolkata, anybody is doing impulse oscillometry?
Yeah, we are doing in our clinic for last few months. Again, courtesy Lupine. I still in a bit dilemma whether we are overdiagnosing asthma by impulse oscillometry.
Okay.
I still require we acquire some more data, to especially pediatric data, and standardize the data as per the age. But yes, it is a very useful tool if the child especially is having a very small airway disease.
So we should have own data and standardization.
We should have our own data, because I have a feeling that we are overdiagnosing asthma with iOS.
That may be the disadvantage of a particular test. Dr. Prakash, you want to add something? Are you doing in Fortis?
The main problem with iOS is that, as everyone is saying, there is not enough pediatric data. So we really cannot come to any
robust. The cutoff values are not proper.
We cannot come to conclusion.
Yeah. So, Dr. Sarath, will you tell something about impulse oscillometry? Or I'll just read this quickly because we are short of time. This impulse oscillometry, it measures pulmonary function test in a passive patient. Minimal cooperation is required by the child. That's why we can do it in under 5 children. Sound waves are superimposed on normal tidal breathing, and disturbances in flow and pressure by external waves are used to calculate airflow resistance. It's a great idea that the obstruction to sound waves by the resistance in the passage of air is measured, and it can detect small airway obstruction. The advantage of impulse oscillometry over spirometry is that the small airway obstruction is detected in a much better way by impulse oscillometry. But still, it is available at very few places and only perhaps at tertiary care centers. In asthma predictive index as well as GINA asthma probability boxes, we have seen that allergic sensitization is considered as a major criteria. How do you detect allergic sensitization? Obviously, to detect allergic sensitization, you need to do allergy tests. So, Dr. Prakash, how do you go about it? Do you advise allergy tests in young children?
So one of the things that we look for in cases of even in wheezing is whether there is aeroallergen sensitization. So I think the time will come when we will be looking for evidence of aeroallergen sensitization in the form of allergy test. Having said that, allergy tests are not really validated in asthma in children as much as they are in allergic rhinitis. Because you may get, now there are two ways of doing allergy test. One is by the best way is by doing a skin prick test, SPT, and the other is an in vitro test where you measure the levels of specific IgE. Even if the specific IgE is positive, it does not mean, it may only mean that the person is sensitized. It does not mean that there is an established allergy to that particular allergen. So that sensitization may be part of a general sensitization. So as yet, allergy tests are not done in a routine child with wheezing. They are much more common in an older child with allergic rhinitis. And here one more thing is, many of us are prone to ask for IgE total levels. Now, we were always being taught that total IgE does not really make a difference. It does not really indicate allergic, that there is asthma or otherwise. However, if you heard Dr. Bush's lecture, he did mention there was a role for total IgE. I wanted to ask him that, but I somehow missed out. But anyway, the moral of the story is allergy testing is not yet routine in a child with asthma. I think that will be the last word.
What about FeNO, Dr. Sarath? Fractional concentration of exhaled nitric oxide. So how far useful in clinical practice and how often you do at your institute?
Again, we have been incorporating that FeNO in our day-to-day practice. As far as this exhaled nitric oxide is concerned, it is going to say whether we are dealing with a case of eosinophilic asthma or not. So a value of less than 20 means that it is less likely to be a case of eosinophilic asthma, and a value of more than 35 in children more in favor of an eosinophilic asthma. So when we treat a child with inhaled corticosteroids or some other forms of medicine, with the response, either you can do symptom assessment as per the GINA guidelines, or we can do a FeNO. So a greater value of 35 or 65 going lesser to 35 or 25, it means that the child has been responding. Second point is, if the child is not showing any kind of response, it means we are dealing with a case of poorly controlled asthma. So we need to do something else beyond our inhaled corticosteroids. But again, it has got both false negative and false positive values. Despite that, it is going to be a wonderful thing because it is a non-invasive test and it can be easily done compared to a PFT. And again, reference values still we need in our country.
Only thing is, it is not specific to asthma. Any atopic disease can cause increase in FeNO. And they say that if FeNO is high, usually it is eosinophilic inflammation, and these children respond well to inhaled corticosteroids. So that is the advantage if at all you have a facility to do FeNO.
Two important points are that you should do the FeNO. If there is a recent attack of URTI, there should be a gap of 4 weeks.
4 weeks
and
at
if you
least.
are using oral corticosteroid, then also there should be a gap of 4 weeks.
4 weeks, right. So
basically,
to summarize,
just one line, whether it's important for primary diagnosis or only as a response to ICS. It's really not
it's an additional confirmatory test of eosinophilic inflammation. Besides that, it has a limited value as far as our treatment trial is concerned. Because anyway, we are going to give ICS trial on clinical grounds. So if FINO will only add that this is a eosinophilic inflammation, it will confirmatory. So in the first place, in under 5 years, it should be confirmed whether it is really a wheeze or any other upper respiratory sound. In children under 5 years, probability of asthma is decided by symptom pattern mainly. Majority of the recurrent wheezers have low probability of asthma. That is because it is viral associated wheeze and they do not require controllers. This is a large chunk of patients under 5 years. Younger the age, alternative diagnosis should be ruled out. And in under 5 years children, ICS is always given as a trial because there is a high chance of natural remission. So it should be called as trial. Now coming to children above 6 years, here is a Ishan, 7-year-old boy. History of frequent cough, nighttime awakening, early morning breathlessness. Most of the episodes are afebrile. He has visited general practice clinic and is nebulized with salbutamol very often. So parents have purchased nebulizer at home. This is the usual story. Salbutamol nebulizer is given 2 to 3 times a day. He misses the school once or twice in a week. So how do you position this child and how do you assess the level of control? Dr. Subhasis?
Now, this child is suffering very badly. If I go through the history, the child is having cough almost every day in the daytime. The child is getting up from the sleep almost 3 days in a week. The child is having activity limitation as the child is unable to go to school, though that is not a qualifier for activity limitation, and requiring multiple time short-acting beta agonist nebulization. That means rescue or relief of drugs are being required many of the times. So this child is pretty uncontrolled asthma, and this child is a candidate for starting something which controls the symptoms. Because so far as the treatment of asthma is concerned, we have two objectives. One, control the present symptom, and reduction of the risk of future exacerbation. So we should start some treatment.
Yeah. So how will you initiate treatment for Ishan and at what step?
Now, here I will like to say one line that this is for the general pediatrician. This is a pretty confusing thing. That why I am doing a control before starting the therapy when the child is a treatment naive. Why I am assessing the control. So whenever we are going to teach the ATM, we must explain that. This is number one. Number two, here the child is having symptoms almost all the day. And the child is getting up from the sleep almost 2 to 3 days in a week. So the child is in a moderate level of problem and the child is in the step 3. And in the step 3, the ideal is low dose of ICS LABA or medium dose of ICS or very low dose of ICS formoterol maintenance, which is used as a MART therapy. And if you ask me what I do in my clinic, I am very much fond of MART therapy. So I will start the child with 100 microgram of budesonide plus 6 microgram of formoterol twice a day and one actuation whenever there is an uncontrolled symptom, exacerbation, maximum 12 puffs per day.
So we'll go to MART subsequently in next slides. Right. So we'll start treatment on step 3. So now GINA guidelines and all the international guidelines, they say that spirometry is recommended. That is, the asthma diagnosis should be documented and objective test should be done. Now, in case of Ishan, the symptoms are very obvious. Still, would you advise spirometry and what additional information spirometry will give? Dr. Prakash?
So spirometry today has become the standard of care, especially when you in a child where it is possible to perform, and certainly possible above 6 years, sometimes even above 5 years if the child can understand. So how does spirometry help you? You see the flow volume loop, and looking at the shape, you can really explain to the parents the difference in the flow volume loop that occurs in the pre and the post bronchodilator. The scooping really goes away in many cases. So parents can really understand this graph, in my opinion. The second thing that they can see is the FEV1, that the change in FEV1 that occurs. So basically, the spirometry puts a stamp of reversible airway obstruction, which you can explain to the parents, and you can even dramatically show them what happens not in all the cases, but in a number of them, where once you are given salbutamol, how the flow volume loop changes and how the FEV1 improves.
But even if diagnosis is obvious clinically, would you go for spirometry? And do you advise spirometry?
Documentation is very important for One is in the beginning, and then when you really want to stop the inhalers at that point of time, also sometimes you often perform a spirometry. That is one thing. Secondly, it tells you the severity. This flow volume loop and the FEV1 definitely helps you to know the severity of the disease. And in my experience, a parent who sees this is the parent who is likely to really adhere to the treatment much more effectively than a parent who has just been told and
You said
labeled.
it. So it is very important in a long-term treatment that parents should be convinced about the diagnosis of asthma, and that is done by a spirometry. It's a confirmatory test. So to summarize, children in this age group, in children above 6 years, diagnosis by objective testing like spirometry is preferable. Level of control should be decided from the history of last 4 weeks. All pediatricians should ask this history for last 1 month, and then only you assess the level of control. Treatment should be started at a proper step, not that all should be started with low dose. If the child is having daily symptoms, nighttime awakening, then you can start to step 3 or sometimes even to step 4. And even in step 1, ICS should be given whenever SABA is given. Now, GINA doesn't recommend SABA alone above 6 years. It should always be associated with ICS. Salbutamol should never be given alone, even as a reliever. And maintenance and reliever therapy MART with budesonide formoterol can be given even in children above 6 years. Now, coming to children about 12 years, Mitali is a 14-year-old who weighs 57 kg, height 146 centimeter. Her BMI is 26.7. That means she's obese. She has been hospitalized for wheezing, again, very frequently, frequent symptoms, frequent use of SABA. And still she's not well controlled. She's coughing most of the days. And she doesn't take part in sports. She misses the school. So obviously, Mitali's symptoms are poorly controlled. She comes in the category of uncontrolled. So how will you initiate treatment? Again, as we said earlier, here also, step 3 or step 4. What is the difference between step 3 and step 4? Almost symptom pattern is same. Only thing is in step 4, lung function studies are done. If lung function is low, that is if FEV1 is low, then you call it step 4. If only you are giving clinically, then you can call it step 3. So let's say, how would you prescribe? What will be the prescription? And here, you should know the doses. What is low dose, what is medium dose, and what is high dose. So all pediatricians should know these doses differ between 6 to 11 years and above 12 years. So above 12 years, 200 microgram twice daily 2 is the low dose. Okay, so that low, medium, high dosage table should be known properly by all the pediatricians. So what will be the prescription for Mitali? Dr. Subhasis?
Now, this child is in a step 3, I think, and this child is suffering from recurrent hospitalization, recurrent ear visit. So I will start this child with 400 microgram of budesonide with 6 microgram of formoterol morning and night. And you can do that with 200 twice, but I will go for 400. And I will keep 1 budesonide 200 plus 6 as a reliever. So that's the way I will start the therapy. And I will definitely try to do some lifestyle modification to reduce the weight because the child is grossly obese, and whether there are any trigger factors in the house or in the surrounding. And if the child is adherent or not, that is the most important issue, because in adolescence, adherence is a big issue. So if the child will take the medication, if the child is not having the triggers around or inside the house, and can reduce some weight, definitely the child will improve.
Yeah. So, Dr. Prakash, would you explain MART? What is MART? We are talking so much about MART, and GINA is also recommending MART at almost.
Let's remember MART as a smart therapy. It used to be called SMART at one time. Single maintenance and reliever therapy. The same reliever is used for maintenance as well as for relief. Now, there are some beauty of the situation is that there is no confusion in the patient's mind what inhaler to use. There is only one inhaler. You tell them that you keep a certain maintenance dose, and in a flare-up, you use a higher dose of the same medicine. The advantage is that formoterol is known as a LABA, but it has definitely got a short-acting action also. So formoterol works very quickly, even though it is a LABA. So formoterol can be used for MART therapy.
Rapid action.
It has a rapid action. The other thing is, most importantly, which Gina pointed out, is that whenever there is a flare up, if you give an additional dose of ICS, it really helps. So this way you're ensuring that your dose of ICS is going up along with the reliever. So reliever and control in the same time, and there is a wide safety margin, as Subhashish mentioned. You can go up to 72 micrograms of formoterol, 12 puffs, and usually much less than 12 is required. So for a patient who can afford it, it is actually a very, very good option. And in any case, for adolescents and older children, this is the second type of treatment which Gina prefers first today. So this, we really prefer MART therapy straight away. Only one thing I will add here, that all my patients on MART therapy, I try to encourage them to use a peak flow meter at home, because a peak flow meter gives a very early warning sign even before the symptoms on when to step up the dose. And they are also very happy monitoring their own asthma if they have a peak flow meter. So MART is very good, provided you are aware of the patient can afford the cost, which is a little higher, and preferably if you can use a peak flow meter at the same time.
Yeah, Dr. Subhashish, you were saying 200 2 puffs or 401 puff can be used.
The only thing is that when the child is controlled, if you give 202 puffs in the morning, 2 puffs at night, then you are giving higher dose of formoterol. That is the only thing.
No, higher dose of formoterol is there. But why I'm saying that, because in MART therapy, we usually prescribe the same inhaler for maintenance and reliever. So we cannot use 400 inhaler for as a reliever. So this 200, that is low dose inhaler, is used for reliever.
Yeah.
So that is the advantage of using
two inhalers you have to keep, which is cumbersome.
Instead of that, if you use 200 microgram inhaler, you can use the same inhaler.
Yes.
Now, there are need gaps in the management of older children also. So, Dr. Sarath, can you tell me about, or what is your opinion, how we are going wrong in practice? What are the mistakes often done?
Majority of the time, point number one, we need to find out whether it is a case of asthma or not. If it is a case of asthma, then whether we have taught the patient properly the technique of inhaler, the correct dose of inhaler, whether the child is using only meter dose inhaler, whether the child is using meter dose inhaler along with the spacer. So technique has to be taught each and every time by the consultants. Majority of the times it is taught by the pharmacists, and majority of the time people doesn't know how to use it. Point number one. Second point, each and every time when the patient comes, we need to find out whether they have been doing the same technique that we taught, because during the course of illness or during the course, invariably they will forget the correct technique. If the patient is getting worsened, despite correct technique, we need to find out whether we are treating comorbids like allergic conjunctivitis, adenoid sinusitis, etc. So despite that, if the child is not worsening, we need to concentrate on environmental factors. That is what our previous speaker taught. So we need to concentrate on all these things first before going to step up the dosage from either from 100 to 100 or 200 to 400. Even a dose of maximum of 400 in a child between 6 to 11 years and a maximum of 400 to 800 between 11 to 18 years is more than sufficient to control majority of asthmatic children.
Dr. Prakash, would you like to add something?
Shishir, last 5 minutes, please.
I'm coming to end.
So I think one of the gaps in management, as Dr. Andrew Bush kept on insisting that look at the basics, and many of us do not give time to check the inhaler technique every time, as Sarath pointed out. We have to do that. That is one of the gaps in management. The second thing is that we use often only nebulized medicines, even in asthma. So only salbutamol is used from time to time. ICS is not really given long enough or properly. The third thing is that often there are comorbidities. Now, you mentioned in the last child that she was obese. In older children, obesity, then allergic rhinitis simultaneously. These are the two commonest comorbidities which has to be addressed to make sure that the child is treated holistically and your treatment is successful. But I think the most important thing is monitoring and checking the inhaler technique, because patients in my experience are very, very creative at making mistakes and a different mistake each time. So unless you check it.
So these are the main gaps which are there in practice. And so guidelines we read and learn something, but often it is not practiced in our day-to-day clinics. And so child may often land up again in exacerbation. Now, what next? I'll skip this because we don't have time. So in the step 5 management, or even step 4, we have tiotropium, which is a long-acting anti-muscarinic agent, which can be given. Oral steroids is a last resort. In our country, because of the cost factor, and oral steroids like prednisolone or cheaper alternative, they are used earlier than the tiotropium or even biologics. So biologics, Dr. Bush has already talked about, so we won't go into discussion on biologics. And omalizumab, mepolizumab, he has nicely highlighted all the benefits of these biologics. Allergen immunotherapy is a topic by itself, and we cannot discuss in short time. So to come to conclusions of children above 12 years, budesonide formoterol combination inhaler can be used as maintenance and reliever treatment for all the steps. MART is very effective in reducing exacerbations and to improve symptom control. It is undoubtedly proved that if you use budesonide formoterol inhaler as reliever and maintenance, then the exacerbations are reduced, mortality is also reduced, even hospitalizations are reduced. If medium to high dose ICS plus LABA doesn't give good results, there are other alternatives like tiotropium or sublingual immunotherapy. All this is mentioned in GINA, and omalizumab or other biologicals like mepolizumab can be considered, but only after referring to asthma specialist and in consultation with some expert and doing some phenotypic assessment or some more investigations. So we have seen that many times pediatricians don't practice as per standard guidelines. There are many need gaps in asthma management, and we as senior pediatricians and asthma trainers should take the lead to fill in these gaps for ideal management of our asthmatic patients. Thank you. That's all from my side. Thank you.
Thank you, Dr. Shishir. That was a wonderful discussion. And I thank all the panelists for, valuably contributing to the discussion to give clear take-home messages to our audience here. I don't have any questions for you. I think you guys did such a thorough job that people are just, all their queries are answered.
People are hungry.
As long as they're not angry with us, we're okay. Thank you. Thank you so much. It was a wonderful evening and a scientific feast. And I think over to dinner now. Thank you so much.
Thank you, Dr. Indu. Thank you, Lupine, for giving us this opportunity. And it was a wonderful discussion.
Any questions here from the audience? Just a moment. No, I don't have questions. Live audience also. Thank you so much.
Thank you so much.
Thank you, sir.
Bye-bye. Bye.
Good night.
Thank you.
Bye-bye.
Thank you so much, everybody, for the patient listening. Actually, this session has been so wonderful because ma'am has stated such eye-opening facts regarding the impact of air pollution and how these are like silent or passive triggers, I can say, who are, at the backseat, they are actually worsening the asthma cases. As well as the panel discussion, which very well and thoroughly discussed regarding the various need gaps that are there. So wherever supporting the pediatric fraternity with respect to the diagnosis or patient awareness or helping the patient to adhere to the therapy, or like Dr. Bush mentioned, correcting the basics. So that's our mission. We as pharmaceutical industry, that's our mission, that we aid the pediatrician in their practice or the HCPs in their practice to help, reach the proper treatment outcome. So thank you so much, everyone. It was a wonderful evening. Now we are open for dinner.